Well, good Friday to everybody here on Friday, March 7, 2025. Great to get to be with you. It was a close call. I didn't think I was going to make it. Had some amazing patients today, including one that was featured in the SADS Foundation recently. Maybe you'll be able to figure out who she is. But from that picture, you might not figure it out because she's all grown up, and was loved seeing her and a wonderful family. New family with long QT syndrome from Michigan. Great meeting that family. Delighted to partner with a very special team. Give a shout out to University of Michigan. Great. Thank you for that referral. But great to be with you for SADS Live 163. I'm Mike Ackerman, genetic cardiologist at the Mayo Clinic in Rochester, Minnesota, and director of Mayo Clinic's Winland Smith Rice Genetic Heart Rhythm Clinic. I'm here on behalf of the SADS Foundation and our CEO, Alice Laura, and I'm just going to be turning off my email so those vibrations don't come on in. And I have loved being with you. I didn't get to join you last week at the last minute. I had something come up, and I heard it was a great interview, but I'm glad to spend Friday with you. So wherever you are, I had a special family. Let me see if I can find it. And I don't think she's joining us, but Julie, if you're there, it was great to see you on our Mayo Clinic Florida campus. And again, just thinking about your grandson, Owen, and sending prayers up to the Almighty Throne for your little grandson's healing. So people would be praying for Owen, 18-month-old precious child with some non-cardiac, long QT struggles. But today is your questions, which are amazing, and my answers, which I hope they will try to match that as close as I can. But before I do, 3 announcements. First, March 19th, SADS Foundation is starting a monthly writing workshop, and the first activity is March 19th. 3 days later, for those in the Nashville area, or if you just want to fly to Nashville, Tennessee, our SADS Foundation regional seminar is going to be at Vanderbilt University on March 22, and great friends down over there from Minnesota, including dear friend Prince Canaveral, will be there. And then a rescheduled program for 3 days after that. So we have a busy March 25. Andrew Landstrom from Duke University. You know him. He's on our board. I trained him, one of my mentees that I am immensely proud of. But he's going to be giving a presentation, a webinar on clinical trials. What are those? What should your expectations be? What are the deliverables? What's the difference between a phase 1 clinical trial and a phase 3? And the good news is there's lots of them happening for our SADS conditions. Never talked about a single clinical trial for SADS really for the first 20 plus years of my career. And now these last 5, my oh my, we're talking about a trial for this SADS entity and that SADS entity, and a new trial launching this summer for a drug trial in long QT syndrome, and a gene therapy trial for CPVT, and current gene therapy trials for PKP2 ACM. It's really an amazing time to be in this field. It's an amazing time to be a SADS family. If you have to be a SADS family, to get to be hopeful and hope-filled. So I hope you are that. And I hope we're doing our part at the SADS Foundation to make you as hopeful as possible. Now, here we go. Top of the queue. And let's go. 36 minutes on the counter. And SADS instructions, keep them short for me, because then we get to Dana. And hello, Dana from Ireland. You know, it's been a long time since I've been to Dublin. I love your country. And Dana's starting it off with a question about LQT2. Patient has multiple breakthrough events, and that's what we call them, and I'll describe that, including which one required the ICD to work. While on the recommended dosage of NALOL, why would they still be required to continue taking it? Oh, I like that question. Great one to start with. And reminder, everybody, I use your question to talk about the general concepts, ideas behind it. I am not giving a specific medical recommendation for you as the person with that question. I hope that makes sense, because how could I do that? The family I met today, I spent 4 hours with them. 4 hours with them. And so I can't possibly give you a directed question, but I hope my answers give you a feel of the issues that need to be considered. So LQT2, second most common type of long QT syndrome. And when we call it a breakthrough event, what we refer to that is a long QT triggered breakthrough event, or a CPVT triggered breakthrough event. And we call those in our vernacular BCEs, breakthrough cardiac events. And it's not a breakthrough as in, wow, that was a big breakthrough. This is more of a negative connotation in the sense of, on therapy, on our current strategy, the person had a breakthrough, meaning their disease substrate broke through that treatment package and they had a disease episode, a disease triggered episode. In the case of long QT, it was either a breakthrough faint and then resolution, or a breakthrough faint followed by a generalized seizure and then it stopped, or a breakthrough tragedy with sudden cardiac arrest, or worse, the ultimate tragedy of sudden cardiac death. In this case, it happened, and it happened while on the desired dose of Nadolol. And so why keep taking the medicine? The medicine didn't work. Well, that would be one view. Another view could be, in the absence of that medicine, might there be more breakthroughs? And obviously not cure, because one still happened, but better than the amount of them that might have been happening with it. Now, I will just share that anytime a patient of mine has a on therapy episode, no matter what it is, to us, that is a cause for a review, a careful analysis of, did we have it understood well enough? Did we missize the risk threat? And did we undertreat, or did we not treat ideally? And so again, for example, I love Nadolol. That's one of my favorite beta blockers, but I love it the most for LQT1. Another beta blocker I like a lot is propranolol. Those are my two favorite beta blockers based upon experience and evidence for long QT and CPVT. Now, it turns out that I think, and others think, that propranolol may well be better for LQT2 and LQT3. So not all beta blockers are the same. As many of you know, I don't like atenolol. I stopped using atenolol probably 25 years ago. It's not an equally effective beta blocker, so I don't like that one. Metoprolol, a lot of ARVC families might be on metoprolol, and that's an okay one for that disease. I don't like it for long QT and CPVT. Great start, Dana. Thank you for that question. And scrolling down and the announcements, and from Leaky or Leak on Instagram platform, type 2 long QT syndrome, so 2 in a row, and a stop codon. And I'm always tired. Is this a symptom normal? Good question. So first, when we say a stop codon, we're referring to a specific genetic variant that caused the gene to build a protein to be stopped before its destination. And we say that that's a premature truncated product. Now, most stop codon, or nonsense mutations as they're called, result in a non-functioning product. Most, not all, but most. And as such, in long QT2, that means if that was the mother's gene that contained the stop codon, then the mother's gene is not building the normal LQT2 related potassium channel. And so the only potassium channel that's being created is the one from the normal dad gene in that example that I just had. And so then that results in what's called a 50% reduction of the normal amount of potassium channel, all things considered equal. And the term to that is called haploinsufficiency. And that is just the descriptor of the exact address where your genetic variant occurred, causing the type of disruption that it caused to, in this case, the LQT2 related susceptibility gene. Now, I'm always tired. Is this a symptom? Now, tiredness is complicated. Tiredness has nothing to do with a stop codon, nothing. Tiredness has nothing to do with your disease, long QT, CPVT, nothing. Could it be ARVC? Yes, because if in structural heart diseases, if the pump is weakening, then that weaker or compromised cardiac output could make a person tired. But in channel diseases, long QT, CPVT, and so forth, tiredness is not a symptom of the disease substrate. Now, could it be a side effect of the disease treatment plan? Absolutely. And what can cause fatigue? Well, remember those beta blockers I like a lot, Nadolol and propranolol, they can. And so one has to look at whether the treatment is resulting in a daily side effect of fatigue. But the disease itself, no, can't do fatigue. Can life do tired? Yep, life can do tired as well. Kim is number 3, and her daughter tests Brugada pattern, has the pattern, asymptomatic, and they did the ECG on you and your husband. The husband shows a type 3 pattern. We were shocked since there have been no heart issues. We know if one else in the family, we don't know if anybody else. Having a very hard time with this with my daughter. Any positive in this that can help me chill out? I like that. Kim, yes. Or as my kids, now grown, age 21 to 31 with 2 in between, would tell me from time to time, chillax, Dad. And for those who don't know, chillax is a union of chill out and relax. So now you know a bit of Ackerman family slang. I don't think my kids invented it though. So how do we chill out? Well, first, one needs to look at the ECG. So whenever somebody tells me that a person is showing the type 1 Brugada ECG pattern, I find myself to be doubting Thomas of biblical era, right? One of the disciples, where I don't believe it until I see it with my own eyes. So I want to see those ECGs because I can only share that I have a lot of patients who were told they show a type 1 Brugada pattern. And then when we look at it, we're like, I don't think that looks like Aunt Sally. I think that looks like Uncle Bob, meaning that's not guilty as charged. So that ECG pattern can be tricky. And so it's always worth a careful review to say, is it a real pattern? Now, if it really is the pattern named after the Brugada brothers, the type 1 Brugada ECG pattern, then that might indicate the presence of Brugada syndrome. It does not mandate it. So that just starts the detective work. And if I have somebody who has that pattern, then I do recommend exactly what was done in this example. I want anybody else related to that person who owns that pattern to get screened for that pattern. Because if another person shows that pattern, then we have stumbled into not just pattern recognition, but Brugada syndrome. May still be asymptomatic, may still be incredibly low risk, but now we're dealing with a disease substrate, not just an ECG annotation. Now, when we call something a type 3 Brugada pattern, that's just noise. That means nothing unless that pattern converts to the type 1 pattern when, say, we move the leads up the chest, do the Brugada ECG, or whether we give a person a chemical like flecainide or procainamide in the United States, agmaline in Europe and Asia. And if now the pattern converts with that chemical, then we have another person who's owning that Brugada substrate. And then we do genetic testing and we go from there. I would say good news is overall, I'm not afraid of that pattern, even if it is a correctly labeled pattern, because most patients who own that pattern are at very, very low risk. So if most are, we might as well assume that your daughter is until we have evidence otherwise. I hope that's the positive, and I hope that helped you chill out. Thanks for the question, Kim. Billy, before prescribing beta blockers for a 50-year-old who tests positive for LQT1, do I perform an epinephrine test under anesthesia? Oh, great one. Never. So epinephrine QT stress testing was actually invented in two places, really. Mayo Clinic by my team in first published 22 years ago in 2003, and also about the same time by a dear friend, Dr. Wataru Shimizu in Japan. Now, the way we infused the epinephrine was different. And remember, 2003, that's before genetic testing. We were still using it to try to make the diagnosis. Fast forward 22 years, the last time I've done an epinephrine infusion test for a patient being evaluated for long QT syndrome was over a decade ago. It's like now prehistoric. And the reason why is we've learned so much. We don't need it any longer. We know how to measure the stress test better. We get a genetic test result back faster. So the only time that I use epinephrine stress testing anymore is when I have a sudden cardiac arrest survivor and we don't know a diagnosis yet. It hasn't emerged. And that survivor is not yet ready to get on a treadmill because of the event that took place. So in fact, we're writing a paper. Stay tuned. The title might change, but it's kind of called Death of the Epinephrine QT Stress Test. So basically, it's now a historical test, except for sudden cardiac arrest survivors. Best question, is there a link between SCN10A and RYR2? Ooh, immediate family, child passed. Oh, sorry to hear that, with SCN10A gene over 20 years ago, and your children have been diagnosed with RYR2 gene after your youngest had an episode. Complicated, but mostly that kind of question of what if there's one gene in one part of the family and a different gene in another part of the family. Are they connected? Are they true, and unrelated? I use that to say, time out, let's do some detective work to figure this out. Now, RYR2 is an irrefutable disease gene. It is the most common cause for CPVT, catecholaminergic polymorphic ventricular tachycardia, remember? So 2/3 of all of our CPVT families are CPVT because of an RYR2 gene mutation. Now, more recently, there's been a new disease linked to RYR2 mutations that's sort of the CPVT opposite. And that disease is called RYR2 mediated calcium release channel deficiency syndrome, or CRCDS, or some people have dropped the middle C and call it CRDS. Now, SCN10A encodes the NAV 1.10 alpha subunit, not the major sodium channel in the heart, which is SCN5A derived. As it turns out, the SCN10A transcript influences the levels, the behavior of the SCN5A transcript, the message, the messenger RNA, and the translated product. But is SCN10A a self-sufficient cause for a disease in the way that RYR2 mutations are? And that answer is not completely sure. The strength of evidence has weakened. And so I would have to figure out first, do I believe that the identified SCN10A genetic variant that was found in that deceased child, was it really the cause for that child's passing? Or maybe the other variant subsequently discovered in other family members might have been missed in that decedent's molecular autopsy. So meaning work to do, I always use these to do some additional homework. Hannah from Instagram. So if I've tested positive for KCNE1, which makes me LQT5, I also battle adrenaline-induced VT, but I think it's not related to my gene. Does this mean anything for my daily life? Whew. Today we are like on fire with amazing questions. That requires some work. In other words, any families that I have that might be having two different things going on in them. And one of my mentors long ago called it lice and fleas. Two things, they're not related to each other, but they both happen to be there in the same owner. I always will pause and try to ask myself, am I sure that there are two independent processes going on? And that can happen. Or is there a way that it all is wrapped up into a single entity? And in a case like this, I do my own homework and I would say, okay, do I really believe that that genetic variant is an LQT5 variant? If so, then okay, then we're dealing with LQT5 and maybe something else. Do I really believe that the adrenaline VT is adrenaline VT, and is that unrelated? Or could it be that back in the day when the LQT5 gene was found, maybe the person only had the long QT syndrome gene panel test done and didn't look at other disease genes, and so might have missed the genetic basis for adrenaline-induced VT. So again, the theme of today seems to be detective work is necessary, because we're posing questions where maybe the answer isn't the immediate obvious answer, but we have some work to do. Howie's asking, are there SADS conditions that are only electrical and don't show any structural issues? A lot of them, for the most part. Now, there are heart conditions in the SADS family that are almost exclusively structural and don't bother the electrical system at all. There's not very many of those. In contrast, there are more SADS conditions that are mostly electrical and hardly bother the mechanical performance of the heart at all. Which one? Long QT syndrome. Long QT syndrome is almost exclusively electrical. Which another one? CPVT is almost exclusively electrical. And then we get to those that are both potentially, which would be the most common of the both, right? Our ARVC families or our ACM families, arrhythmogenic cardiomyopathy. In fact, under the header cardiomyopathy, which means heart muscle disease, the classification changed a few years ago, where we added sort of a umbrella term. We had HCM for hypertrophic cardiomyopathy, where the main problem was maladaptive thickening of the muscle. We had DCM for dilated cardiomyopathy, where chamber dilatation, large ventricles, was the main feature. And then we added A for arrhythmogenic cardiomyopathy, where in that heart muscle disease, a prominent feature was the A, the arrhythmias, and sometimes the arrhythmias or the electrical could precede any structural changes in the heart muscle. So before, it could actually be called a CM cardiomyopathy. Now it turns out that it's not as clean as that, because the HCM, hypertrophic cardiomyopathy, can and does also have A's, arrhythmias, and so forth. But that's how we kind of divide them up. But for the most part, the ones that is almost purely electrical without structural issues is long QT syndrome the most common of the genetic channelopathies. And then from Melissa, is there a correlation between QT prolongation with connective tissue disorder? Doesn't mean causation, but could there be a connection? And connection makes sense to connective tissue disorder. That's a really good question, because we know, for example, that there is congenital long QT syndrome and acquired long QT syndrome. Now, I don't really like the term acquired long QT syndrome. For me, I tend to keep long QT syndrome meaning genetically mediated familial long QT syndrome. Whereas acquired factors, exogenous factors, drugs that bother the QT interval, diseases, non-heart diseases, for example, that bother the QT interval, rather than calling those acquired factors long QT syndrome, I kind of prefer to refer to those as acquired QT prolongation, because I want to keep long QT syndrome very isolated. Now, that might be potatoes, tomatoes, tomatoes, but that's how I do it. I think it's a helpful construct. And in that question, there are lots of drugs that can annoy the QT interval. You know that. There's a website devoted to those medications that are potentially QT prolonging, www.crediblemeds.org, a fantastic resource, not perfect, fantastic, and an app that you can have available so you can do your own safety checking. There's also not just a lot of drugs that are potentially QT prolonging, but there are diseases that annoy the QT interval. For example, diabetics can have longer QT intervals than non-diabetics. And in the connective tissue realm, patients with RA, rheumatoid arthritis, for example, they can have slightly longer QT intervals than those who are otherwise healthy. Lots of disease states. So yes, there is a potential for various disorders to aggravate the QT interval, and that doesn't have to mean that there is long QT syndrome lurking beneath. Now, could it be? Yes. So for example, what if I have a person who has a reaction to a drug that's on the list, but that reaction is like dramatic, more than what I would have expected? Might that mean that that drug was given to somebody who had otherwise beneath the sea a quiet, dormant long QT syndrome mutation, and it was just happily dormant, but it got poked and it reared its head because of a QT stressor like a QT prolonging drug? So you can have both acquired QT prolongation superimposed on somebody who had long QT syndrome. Andrea, can arrhythmias due to long QT syndrome affect the valves as well? My daughter was diagnosed with mitral valve insufficiency, later diagnosed with type 1. After she started on metoprolol, the insufficiency has decreased. Mostly no. So the long QT syndrome almost never has a valvular phenotype. Now, having said that, can a long QT syndrome patient have mitral valve prolapse? Yeah. Why? Because mitral valve prolapse is one of the most common valvular abnormalities or peculiarities. And about 1% to 2% of all of us, by virtue of being alive, have mitral valve prolapse. So that means that 1% to 2% of all patients with long QT syndrome might also have mitral valve prolapse. But the long QT had nothing to do with the prolapse. That's the lice and the fleas from a little bit ago. Another one, bicuspid aortic valve, is a finding in about 1% to 2% of all of the planet. And it's present in 1% to 2% of all of my long QT patients. So once in a while, we might have to also observe the behavior of that valve over time, but that valve's behavior isn't going to have anything to do with the long QT or the CPVT or any other SADS condition that might be present. Dana gets a bonus today. She gets 2. What criteria do I use to decide not to treat somebody with long QT2? Now, we can extend that from LQT2 to all of our long QT syndromes. And it turns out that knowing you own a genetic marker for whatever SADS condition and choosing not to treat is very, very difficult. And we decided about a decade ago that as difficult as it might be, we need to do it because we are almost certainly over-treating some people. And our guidelines kind of help that over-treatment in the sense that it calls for basically prophylactic drug therapy in all long QT patients with a positive genetic test. Now, it separates it from you must do it if you have a genetic test and a long QT interval, or you can do it just because you have the genetic marker, even if the ECG looks normal. And so you can imagine that we have started this process. I currently take care of over 200 patients where we know they own the family genetic marker, but we're choosing not to treat prophylactically, but just doing whatever would be the prudent preventative measures for that particular SADS condition. Now, who might that be? You can imagine that we're starting with the group where we feel the most confidence to declare them at ultra low risk. We don't yet have the ability to call somebody 0 risk. We're not smart enough to make that level of a declaration, but we're getting close. So who might be some of my non-treated patients? Well, how about a man, age 40, never a symptom in his life, but through an incidental chain reaction is found to have an LQT1 variant, and yet his ECG looks completely normal. Well, he is so low risk that we don't need to go from 40 untreated years to now 40 beta blocker years and then make him miserable on beta blockers. So that would be a very low risk person. Now, I don't care your age. If let's say you've gone 40 years, but your ECG shows a whopper, for whatever reason, your QTC is long, and yet you made it 40 years with never a symptom. We're not yet ready to say, well, since you did 40 years with no treatment, let's keep doing no treatment, even though we now know about it. So you have to decide non-treatment very, very carefully. A follow-up to Kim's question, and Kim's question, I believe, was about the daughter with the type 1 Brugada pattern, the dad with the type 3, and they did a genetic test and it was negative on her daughter. Now, remember, a negative genetic test for Brugada syndrome does not rule out Brugada syndrome, because as it turns out, most of Brugada syndrome is not even going to be a genetic disorder. And that's why there's often not any family pattern. Most of Brugada syndrome is not monogenetic, meaning my mutation in one gene caused my disease called SADS X, Y, or Z. That link to a 1 = 1 is 2, and the cause for Brugada syndrome is about a 20% chance, maybe a little higher depending on the ECG, a little lower depending on the missing ECG findings. But that means the majority of Brugada syndrome that's correctly diagnosed based upon the ECG pattern will have a negative genetic test. But that negative genetic test, nevertheless, if it's negative, that at least lines up with the possibility that maybe we overreacted to that ECG pattern. So I would always use a negative genetic test result for Brugada, even though the yield is low. Long QT, where the yield is high, 80%, 90%, to make me return to Exhibit A and say, despite that negative test, am I still going to call that person that disease? If so, so be it. Then they're genotype negative. If that review caused me to sort of reconsider the strength of the evidence, then we might be able to step backwards a little bit, rewind the clock, and potentially change the story. And 5 minutes on the counter, Maria from Instagram, her son is type 1, I believe probably type 1 long QT syndrome, 9 months old, currently taking propranolol every 8 hours. His current EP said we will switch around 1 year old to Nadolol. Is that's what you would do? Can't speak what I would do, Maria, for your specific son. I can tell you what I do for my LQT1 boys, infants, where I am thinking about their treatment strategy. In my program, I start LQT1 infant males on Nadolol immediately. And I like liquid Nadolol for LQT1. That liquid suspension allows me to dose it just twice a day. So I kind of like that better than the 3 times a day requirement with propranolol. So if I felt that I needed to treat an infant with their long QT syndrome, if LQT1, I generally am using liquid Nadolol immediately. If LQT2 or LQT3, I probably find myself doing propranolol and potentially keeping propranolol unless I make a decision to do mixilotine. Lot of ways to review that. And let's see. Oh, Megan's is a long one, and I don't think I'm going to be able to unpack that well enough. So we're going to have a note to Erin, and Erin on our SAD team is amazing. I couldn't do this without her. We're going to mark Megan's as the first one to do next time. And so when is next time? I don't know. Let me see. I think next time might be in 2 weeks. Yep, no. Yes, maybe. So when we get together next time, I think it's March 21st, but I have what looks like some double scheduling. So I have to figure that out. But until next time, I hope this has been helpful. I hope this has helped you feel hopeful and hope-filled and able to chill out, as one of our dear SADS lives nation, SADS Nation people have shared with us today as the word of the day. But I've enjoyed this so much. I hope you have a wonderful weekend coming up wherever you are here in the United States, maybe up north, from our SADS Canada, maybe in the UK with SADS UK. How about SADS Asia, SADS Thailand, wherever you are, SADS down under. I hope you feel that we are doing a good job as a caretaker of your SADS condition in terms of a nonprofit advocacy organization to meet your needs. And if we are, go to SADS website today, www.sads.org, or if you prefer, www.stopsads.org, and go to that top right corner where it's a red rectangle says donate now, and feel free to. And now, if you cannot, grab a friend who has the financial means and the potential interest in your condition to partner with us in that way to help us meet your needs as best we can. So until next time, great to get to be with you. And I look forward to seeing some of you starting on Monday on our Arizona campus, where I'll be heading to see patients at Mayo Clinic, Arizona. Look forward to seeing you there. Till next time, live and thrive.